Welcome to the Disease Du Jour podcast on the topic of Rhodococcus equi pneumonia and Foals with Macarena Sanz, DVM, DAC VIM, PhD, and Assistant Professor in Veterinary Clinical Sciences at Washington State University. I'm your host, Kim Brown, publisher of Equi Management. The Disease Du Jour podcast is brought to you in 2022 by Merck Animal Health. Dr. Sanz began her duties at Washington State in 2015. Prior to that, she was a postdoctoral assistant at the Gluck Equine Research Center, where she got her PhD in equine immunology and infectious diseases. She had previously earned diplomate status in large animal internal medicine and her master's from Washington State in equine pain management. Dr. Sanz received her DVM in 2000 in her native Argentina. Welcome to the podcast, Dr. Sanz.
Thank you very much, Kim. I really appreciate being here today.
Well, I'm really excited, and I know our audience is too, because we're in the perfect season for you to tell us a little about your research and to share some knowledge about our equine pneumonia. So I am just going to turn it over to you and let you tell us some information.
Super. I think what my idea for this time was to put together what we know so far and some of the stuff that is new, because we do have a fair amount of new research coming up that is very exciting, and I think it will be useful for practitioners. So that was the idea. And why do I get into Rhodococcus and I like this research so much is because Rhodococcus is very common infection. It affects young foals all over the world. So if you do any foal work, you will come up with Rhodococcus, unfortunately. And we don't have a vaccine available to prevent this disease, which makes it more problematic to deal with. So a little bit tiny touching on Rhodococcus itself. It's a gram-positive bacterium, and the thing that is very important is to understand that it's everywhere in the soil where you have horses around. And the reason is before we knew that it was present in a fair amount in the manure of normal foal horses, so mares, we used to move these mares around the paddocks all over the place, trying to prevent or getting them to a clean paddock. But now we know, while you can decrease the amount of manure out there, moving horses around doesn't do you a lot of good because the mare goes with and they have it in their manure. But we do know also that the manure of the foals that are infected and their nasal discharge, they have a lot more than most mares. So they are kind of like the main shedders, if you wish, of a place. And then once it hits the ground, foals will get it by mouth or inhaled, but anything that has to do with aerosolizing these samples. High concentration of horses, when you move them a lot. Again, we were moving these horses back and forth, and that made Rhodococcus aerosolize more. So then we were getting them together. So those were things that we were doing worse, trying to do good. If you are in a barn with low ventilation, then for sure more Rhodococcus there. And if it's dusty and dry, then of course all that dust getting her up. So I think it's everywhere. That's important in the mare, so you have it in the foal. And then the other thing to understand about Rhodococcus is you can have a lot of Rhodococcus, but not all Rhodococcus will infect foals. So there are Rhodococcus that are non-pathogenic. They're just part of the flora and part of the soil population. And then there are the ones that are pathogenic to foals. And the difference in between a non-pathogenic and a pathogenic is a surface protein that is called VAP-A, virulence-associated protein A. And that is very important when we go to diagnostics, because you can find Rhodococcus pretty much in the manure and in some of the lung samples of foals because it's everywhere. But in order to say that is the one bacteria causing the disease, you need to test for this VAP-A to be sure that the Rhodococcus is pathogenic. So I think a lot of the times we see the laboratories do culture and PCR together just to say, yes, it is Rhodococcus, but it's also pathogenic Rhodococcus, because otherwise it's very common everywhere. So once the foal they inhale it or eat it, they will get affected. But adult horses are resistant to infection. And unless they're immunosuppressed, Like we had some cases, for example, horses with lymphoma can get Rhodococcus disease. I had a horse with leukemia, a different form of cancer. So those are, yes, they can develop Rhodococcus, but if their immune system works well, then they won't. And this is true for people. So this Rhodococcus is an important disease of people that had organ transplants or with HIV infection. And it's becoming a big problem because we have a lot of people out with this type of problems, right? So they might have surgery and they're on immunosuppressive drugs. And also small animals. So cats and dogs. We actually had a dog in the clinic about a month ago that was on immunosuppressive drugs for a different treatment, something related to skin, and I showed up with severe rhodococcal pneumonia because the dog lived with a horse, and we think that's how she got it. So in dogs and cats, we do see a fair amount. It's usually a delayed diagnosis because nobody thinks of Rhodococcus as a first diagnostic. But nonetheless, adult horses absolutely unfazed by this if they're healthy. But foals, though, foals is a different thing. They do become infected very early in life, pretty much as they're born. They come in shortly after birth. We know because it's everywhere and in the mare's manure. And usually they are susceptible into an early age. No, we say no more than the first month, but in reality, it's the first 2 to 3 weeks. And this is new. This knowledge that they're only infected early on is just new from the past 10 years. And we have been doing a lot of research with the wrong idea. And I'll get back to that a little bit later. But that is very important because it's changing the way we think about Rhodococcus. The one thing we still don't know is why foals. What makes a foal that is 2 weeks old be susceptible, and an adult or a foal that is 2 months old that might not be? And we don't know. I think it's going to be a combination. That's part of the interest I have on the research. What makes them susceptible? We know they're not born with an immune system that is fully functional. But we cannot tell right now which part or parts of that immune system is responsible for this susceptibility. How do they get it? Well, they get it by mouth. So we know foals actively eat the mare's manure, and that's how they colonize their own gut with bacteria. So they will eat it. They also, as they're trying to nurse, the manure might be running down the mare's legs and the others. So they're always in contact. What we don't know a lot is about this oral route. What is the role in the pathogenesis? In the early years, when we didn't know much about Rhodococcus and we didn't have good ways to diagnose it early, we saw a fair number of these foals that develop enterocolitis or enteritis, severe form of intestinal disease. We don't see as many now, still out there, but not as many. But we don't know if that is out of oral infection or it's just a systemic infection that lands on the gut. So we don't really know. But unfortunately, this oral, this enterocolitis disease, and it carries a little bit worse prognosis. Again, maybe because at the time we caught them very late, so it was very advanced, and we don't see it as often right now. But the main route that this falls, and most of the knowledge that we have is about inhalation. So when they inhale this bacteria, it gets all the way deep in the lung, which is different than some other bacteria, to the very end of the lung and infects the macrophage there. The alveolar macrophage is kind of like the target cell because the macrophages are responsible for cleaning up any bacteria that makes it that far. If we have a Rhodococcus that has VAP-A, and it's a VAP-A positive, so one of these that can cause disease, then the macrophage will eat it like it will do any other bacteria. But this Rhodococcus can escape killing inside the cell. And also because it's inside the cell, the body doesn't know it's there, right? So it's hiding inside the macrophage. And in there, it replicates and replicates until there's no more room. Then it bursts that macrophages and infect other macrophages around the area. And that's what we get. What we have is called a granulomatose. So a lot of cells, slow growing, but persistent growing, very similar to human tuberculosis. So when we think about Rhodococcus in Foals, we should think about tuberculosis in people. And you can have this slow growing disease for years before you become clinical. For us in Foals, it's very similar. It's just months. It's just a shorter period of time. And that is the reason that slow, insidious growing that we usually saw clinical signs when they were 3 months to 4 months of age. So before we have ways to look into the chest, like for example with ultrasound, we thought they were getting infected at 3 months, because that time is when the antibodies from the mare decreased. So it was kind of like made sense to say, well, they're more susceptible to infection. So everything we did research-wise was under that premise. And there are like we spent years infecting old foals. And the problem is when you try to infect old foals, you have to give them a truckload of bacteria or they won't get sick. So you have to put it down in the trachea all the way, tons of it. And then what you get as a result is a very severe, almost fulminant pneumonia that has nothing to do with the disease we see. So when we were trying to infect these foals, for example, to see, will a vaccine work? Will plasma work? Well, nothing worked because the disease was very severe, and foals will end up euthanized. You have to euthanize them in 2-3 days because they develop these massive pneumonias, no time for abscesses. So the disease was very different. And now we know that they're early. They get, as they're born, that first week they're infected. So that has changed the way we do research. But of course, we have a lot of resources and years of research spent where we can really use that information anymore. We've learned a lot of things, especially out of a lot of the in vitro stuff. But with the in vivo, I feel like we have to redo a lot of these things only because of the model. So we now have a better model that takes very little bacteria to get into the trachea of these foals, and then they will get this disease. The problem is if you decide that Rhodococcus is going to be what you do for research, like in my case, it's not cheap and it's not easy because we have to wait for the whole year for pregnancy, right? 11 months before we can get foals to infect. And that is extremely costly. So the other thing is foals are very different. It's not like mice that we have, all mice are the same, genetically equal. So then we deal with individual variation. And then you need a larger number of foals. And again, more expensive. And honestly, there isn't a lot of money devoted to equine research just because there's not a huge market for anything you do, right? So small animals and production animals are way above. So people tried to do other animals. Can we use other animals for models to speed up the things we do? And the answer is no. So mice, for example, would be fantastic if it would work. Mice are only susceptible if you wipe out their immune system. So they have to be genetically modified, absolutely immunosuppressed, and then we can get them infected. But then they get a very different disease. They get systemic disease, bacteremia, not the abscesses in the lungs. We try small ruminants like goats, and they get some infection in the lymph nodes, so not pneumonia. Guinea pigs, which are guinea pigs, sounded close enough. And guinea pigs, again, super resistant to infection. You give them different loads of bacteria and nothing happens to these guinea pigs. So not a good model. So we're left with infecting foals and not a lot of resources to do that. And also, it takes, if something fails and you need to redo the research, then it takes another year to get ready and, decide, I need to adjust the dose or maybe do a vaccination at a different time. So it's slow. That's the biggest thing.
Today's Disease Du Jour podcast is brought to you by Merck Animal Health, the maker of prestige vaccines, Banamine, Panacur, Regimate, Protozil, and other trusted equine health solutions. Merck Animal Health works for you and for horses. Learn more about Merck Animal Health's comprehensive portfolio of products, as well as their ongoing investment in our industry, profession, and community through programs such as the Respiratory Biosurveillance Program at merckanimalhealthusa.com.
But going back to this, a little bit of the pathogenesis, we do know that foals, if you have foals in a farm that we call endemic or that has problems with Rhodococcus equi, which is pretty much most farms that have a fair number of foals, at least half of the foals will be infected with Rhodococcus and will have some sort of subclinical disease. The farms I work with before they have somewhere close to 70%, 67, which means that 6 or 7 foals out of 10, if you ultrasound them, will have lesions in the lungs. That doesn't mean they have clinical signs, but they have lesions in the lungs. Now, what is super interesting, and that is the main focus of my research, is, okay, of the infected foals, the ones that we look with the ultrasound and have lesions, only about 20% develop clinical disease. The other 80 or 70 or 80% will clear the infection on their own without the aid of treatment. Why is this? Why are some foals, that 20%, why are they susceptible? We don't know, and it's the $1 million question. Can we identify that 20% and only treat those and closely monitor the other ones? We wish we could have a tool to do that, because then it will minimize the amount of foals that we're treating for sure. So, and we'll get back to this, 20-80% when we talk about treatment and resistance. As far as clinical signs of disease vary. They're going to vary with the location of the infection. But the most common form is the pulmonary form, so pneumonia. And it's no different. I think fever and lethargy are the things that people pick. There might be anorectic. When you have a crew, usually farms that have endemic Rhodococcus have a very well-trained crew that walks around the paddocks, and they can pick up these foals. What you see is they're not playing as much as the others. They might be standing still, and they have a little bit of a faster breathing, faster respiratory rate, or maybe more effort to breathe. And this is a lot worse if it's in a place where it's hot and humid. Where I used to work in Argentina, that was the weather, and we could pick up these foals very easily. I think by the time they're 3 months, for example, here in Washington, we have a drier weather, so it's not as bad. You'll pick them up, but I think the hot heat and humidity puts a lot of strain on these foals. They might be coughing. I think that's when the disease is a little bit more advanced. And nasal discharge, same thing. By the time you have nasal discharge, then there's a little bit more advanced disease. And I think people in farms, they pick them up a lot sooner than that. And of course, if you have foals that are not watched, that's closed, and they had disease for a long time, then weight loss, these foals are not growing as much, their hair coat is not good, and they have that chronic cough and nasal discharge. And then the other thing is, Rhodococcus, on top of pneumonia, gives us what we call extrapulmonary lesions. And these lesions are, like the name indicates, is they're outside the lung. They can be anywhere. So we talked a little bit earlier about that gastrointestinal infection, and things that we see with that is maybe the foals have softer manure for longer period of time, or diarrhea, very poor growth, poor hair coat. And this one is fairly deadly, or used to be fairly deadly. Again, I think we were catching them a lot later. But Rhodococcus can also get into the bone. And it has this predilection, we think, because it gets systemic. So bone growth plates, vertebra. So sometimes we get abscesses in the neck or along the spine. And those are extremely hard to diagnose, because the only thing you know is I have an abscess somewhere. But depends on the size of the foal, we may or may not be able to do a CT or see it with ultrasound. And many times we're just treating this blindly without knowing where we're treating. And unless you treat with the right set of antibiotics, Rhodococcus will keep growing because it's very resistant. It's very hard to kill. And that's why if you have a foal that has clinical signs or blood work signs of consistent with an abscess and you are in an endemic farm, your choice of antibiotics might be those for Rhodococcus, because otherwise there's a fair amount of time that you'll be treating and the foal will not be responding. And again, like I mentioned, the hard not being able to get a sample is just the most common scenario for this, because many times we don't even know. It's in the middle of the abdomen. Is it somewhere in the spine? We have no idea where it is, so we can't get a sample. And then a little bit of a different, less common presentation is what we call immune-mediated polysynovitis. And this is just the immune system reacting to Rhodococcus. It's not the bacteria. It's just that the immune system reaction affects the joints. And you'll see foals coming in with a bunch of joints that are swollen or effusion in the joints. And they're usually not super painful. Like if we have a foal that walks in with effusion in the joints, we're thinking about some sort of septic arthritis. And that would be poor prognosis. We need to flash. We need to do all kinds of intra-articular antibiotics and systemic antibiotics. And these foals usually respond to corticosteroids. And as we get rid of the infection, then the immune system quiets down. So corticosteroids for these foals. And it's important to keep in mind that because they're not as painful, like I say. I think it's a lot of effusion, multiple joints, so it's scary to see, but they turn to do fairly well. And as far as the prognosis, if we have the pulmonary form, we have very good prognosis. Like most of those foals, we put them on treatment, like over 90%, and they will do absolutely fine. It's a long treatment, and we'll discuss that, but they do well. For all the extra pulmonary lesions, it all depends where it is, how soon can we start treatment. If we have, for example, foals, they have a vertebral abscess, I don't know, in the neck, those are really hard to treat, or osteomyelitis. So it depends where it is, how much is affected, how soon we can get it. But of course, the prognosis is, we say, a little bit worse, although we put them on treatment and then we see how they do. But it's a little bit less predictable, let's say. If we're suspicious of a foal with Rhodococcus, in general, the farms where Rhodococcus is endemic, I think any pneumonia is bacterial pneumonia is bacterial pneumonia. It doesn't matter if it's Rhodococcus or not. So the idea is that you would do the diagnostics that you would for any bacterial pneumonia. And in the case of foals, is just perform a transtracheal wash, which is to take a sample of the fluid in that trachea. And there are two ways to do that. You can do it using an endoscope, as long as you have a special tubing that goes through and is sterile, because we need a sterile sample. Or we do here a lot of percutaneous, so through the skin, a small needle in with a transtracheal wash kit that they come commercially available. And then we take the sample and we submit that sample for culture. If you have the ability to culture and PCR, so we know that it's Rhodococcus, but it's the pathogenic Rhodococcus. Sometimes you don't have that option, depending on the lab. And then always, and this is true for any pneumonia, always culture with cytology, because the trachea is not sterile. There are microorganisms there. So unless you have a cell indication like inflammation, suppurative inflammation, a positive culture doesn't mean that it's a bacterial pneumonia. And that is true for all these diagnostics that we do for pneumonias. And in general, the farms, what they do is they send the first one or two to the labs just to be sure that's what they're dealing with. And then after that, in an endemic farm, because you have 50 to 60% of these foals with some sort of lesion, then we make a diagnostic based on the age. These are 2 to 3 months old foals, the fact that you're an endemic farm, clinical signs, and then we see the abscesses that are very characteristic on ultrasound because they're on the most caudodorsal part of the lung. You can see them well, might be more than one. So we don't need to send a sample for every single fold. I think once you have that, then it's easy enough. The problem is, ultrasound is fantastic. I think ultrasound, thoracic, having the ability to look into the chest has made us realize, like, for example, that the infection is a lot earlier than what we anticipated. But the problem is, we've been using, since the 2000s, we've been using this ultrasound as a way to screen folds. So before, you would wait until you saw clinical signs, and then we would treat those forces, and we were treating about 20%. Then we started doing these ultrasounds. And with ultrasound, we realized, as early as 6 to 8 weeks, these folds have lesions. They have abscesses. And they have abscesses on both lungs, and these abscesses keep on growing, and they might be actually some substantial abscesses. And that's when we started treating every single fold in the farm with antibiotics. And that, of course, decreased the number of folds that went all the way into developing clinical signs. So it was, if you wish, success on that side. Yes, we got a lot of treatments. Of course, treating is not cheap. Involves a lot of human power, manpower, because these are oral medications. We have to go catch these folds and treat them. And it's long-term, but prevented the disease, the development of folds with fever and cough. And only problem is, as we were treating so many folds, of course, the end result of that is resistance. So now we have a huge problem, especially if you work in places like, most of the information we have is from Central Kentucky, but I don't think it's any different if you're in areas where there's a lot of treatment. Treating too many folds for many years, of course, landed us on antimicrobial resistance. And the problem with resistance is, there are multiple problems with resistance. One is, folds that are infected with a resistant strain are a lot harder to treat, and they die more often. They're 7 times more likely to die than a fold that is infected with a non-resistant strain. And the prognosis, like I said before, if you have a pulmonary, fold with pneumonia, you treat them as 90%, that drops to 40% survival. So 4 out of 10 instead of 9 out of 10 if you have a resistant strain. The other problem with resistant strains is, we treat the folds. We mentioned that the folds that are infected and sick are the ones that shed the most. So if they're shedding resistant strains, the next crop of folds are picking up those strains. And also the mares, as they're grazing, are picking up these strains and shedding these strains with our manure. So we're selecting for resistance, and then our new crop of folds get infected with resistant strains. And then on top of that, there's a lot of work done out of Georgia University about resistance. And they saw that this resistance, the genes that encode for this resistance for Rhodococcus, are inserted in mobile elements. They call them mobile elements. So maybe we have one bacteria, one Rhodococcus equi has the gene that encodes for resistance, and it can transfer to a completely different bacteria in the environment. So now we have other bacteria that could pick up that resistance. And that bacteria might not be just for infecting folds. It might be infecting cattle or people. So that is the downside of this fantastic idea that we have about scanning and treating everything. And on top of everything, the drugs that we use to treat people are very similar to the ones that we use to treat horses. And we don't have an option. We right now have a group of antimicrobials that we'll discuss, but basically macrolides and rifampin. That is it. And we're not going to get new antimicrobials. So I think we need to be very conscious. This, again, is very new, this whole idea of we're treating too many, we're faced with a huge problem. It's because now we're looking to see, is there resistance? And we're finding a ton of resistance. And at the same time, as we were doing this treatment screening, treating a lot of folks developing resistance. We were very lucky that a group in Germany that is led by Dr. Benner, they had a massive operation there with a lot of falls every year. And they were trying to see, since they had a big Rhodococcus problem, can we find a treatment that instead of being twice a day is once a day, or is there a better treatment so we have to treat for less days? And very luckily for us, their experimental design allowed us they included controlled, not treated falls. So before, here in the US and everywhere else in the world, I think, when people were doing research, trying a new treatment, we would always compare the gold standard treatment versus the new treatment. But we never had a non-treated group. So when Dr. Benner's group started to include a non-treated group, what they saw is that there's this 80% of falls that no matter what we hit them with, we can do hand imposition if you wish, and they will get better, right? And that shows that a good study design where you have a control population, that was revealing to all of us. We're like, oh, we were thinking that these antimicrobials we give fix everything, when in reality it's the fall fixing everything in 80% of the cases. And I think that is her studies, and then subsequent to that, right, there are a lot more, but her studies is what opened everybody's eyes and say, we are treating too many, but there is the option, we don't have to. And now we're all focused on trying to see, okay, which ones do we treat? How can we get the closest we can to that 20% that really needs treatment? And we don't have an answer yet, but I think we're getting close. So some of the new approaches that she's developed in Germany and that we're using here in the US, and there's some new studies out of Lexington also, we're trying to use a combination of things. So for example, everybody scans the falls. Maybe we're not scanning them as often. So now maybe they'll get scanned every other week instead of weekly or twice weekly. We were scanning these falls twice weekly before. And we were treating anything, like an abscess that was 1 centimeter of diameter, we were treating. Now we developed this idea that maybe we just add all the abscesses, we measure all the abscesses, and then it depends on the farm and on the comfort of each veterinarian, because you have to know your farm. It's not going to be a one rule fits all. We go for a sum of abscesses that are maybe 15 centimeters or 12 centimeters. But it's not only that. You have to also look at, okay, what is the white cell count? So if they have multiple abscesses and they're big and a very high white cell count, which depending again on the farm, might be 18,000 or 16,000, and a high fibrinogen, 800, 900, then you treat. And Dr. Benner they just recently published an article, and they were trying to stretch. Every year they will stretch a centimeter or two these abscesses, and they will increase the white cell and the fibrinogen. So they started with, we're going to treat only 6 centimeters and a fibrinogen of 600. And then the next year, so nothing happened, right? They didn't have any more death. So the next year, they increased that, okay, we're going to do 8 centimeters and maybe 10,000. And now they're like 16 centimeters and 18,000. And you still no more death than what they had before when they were treating everything. But they're treating half or less of the falls. We're still not to that 20%. But it's a compromise, right? So I think we're getting a lot closer, and I think now we all know that that's the way we need to go. And I foresee that this is going to be fast. We're gonna find a balance that is much closer very soon, I think, because most of us realize that what we were doing is no longer sustainable. I think we need to spread the word that this is what's happening, and things like this podcast will help. And because not everybody is aware and not everybody has access to these new papers, right? You have to pay a subscription. I'm lucky enough that I work at the university and we have access to all these publications, but having the time and the access, especially the access, is not for everybody. So I really appreciate this type of opportunity to share with people. And then if we look at the treatment very quickly, I think treatment is very standard. It has been for the longest time. We made some progress on this, but I think it's one of the least progresses for now. Always a combination of a macrolide. So we have new macrolides now, azithromycin and clarithromycin. So always a macrolide and rifampin. And the advantage of azithromycin is you can do it once a day for 5 days, clarithromycin, and then every other day after that. So if you have to treat a lot of Foals, that helps. Clarithromycin, maybe a little bit better. We do it twice a day, so it's a little bit more work. But either one of those two modalities works. The only problem is you have to treat these Foals for 6 to 8 weeks. So if you have 1 or 2 Foals, it's no big deal. But when we were treating a lot of these Foals, I used to work on a farm that had 180 mares falling. So that's 184. By the time we finished crashing the tablets of the morning treatment, we had to start again crashing the tablets of the afternoon treatment. And it's like a never stopping medication of horses for months. On top of that, there's some side effects that you have to be careful. And a lot of these macrolides, they inhibit the ability of the foal to sweat. So you have to bring them inside or have it very well ventilated because they will die of heat stress. So we were moving these Foals out at night and bringing them in before, the early morning. And now you have to clean all this bedding that maybe if you weren't treating, these Foals are outside. So those are the things that are important. And Foals can't sweat for up to 2 weeks after you finish. So it's a very prolonged treatment, like management. And it takes an army of people to go get the mare, get the foal, crash the tablets, get them ready. So a lot of money into that, not just the medication, but the personnel to do these treatments. Because of this, there are other macrolides that we are looking into that are called monodoses or monotherapies, because it's a once-off dose every few days, like usually once a week. Tulathromycin is one, not as effective if you use it alone. There's a recent publication just this year where they looked at tulathromycin and rifampin, and it seemed to be that it's a good alternative. Now we have to be very careful because these monotherapies have been only tested on Foals with mild to moderate pneumonia. So we don't know if it's going to be as effective if you have a more severe pneumonia. And then gamithromycin, which is also an intramuscular once a week, worked well. The problem is a lot of side effects. So these Foals had swellings and they were lame, like 60%. So 6 out of 10 of these Foals had some sort of problem. And some of them were very painful. Like a third of those Foals were like really lame. They all resolve on their own. But when we're looking at giving multiple doses, because this is not a 1 week only, it's just week after week after week, then I think I wouldn't pick gamithromycin myself if I'm looking into doing these treatments. So right now, the recommendation for most groups that do research on Rhodococcus and most experts is not to use these monotherapies on their own. We have to see what this tulathromycin combination with rifampin does in the future because it's fairly new. Might get maybe some traction there. It will be a lot easier, although you still have to do the rifampin once a day by mouth. So it's not like it's a once a week, but it gives you less stuff to medicate. This macro, every time we put any foal or any horse on antimicrobials, diarrhea, right, is a possibility. In general, Foals have a self-resolving diarrhea, but if not, you have to swap medication, and that's a problem. We don't have a lot of alternatives. So something like doxycycline, rifampin, some people are trying. We don't have a lot of data on that. I think we have tried all antibiotics, all forms, all formulations, and so far we land on, back to macrolides. And that's why the resistance is very important because we don't have good alternatives. There's also reports, there are older reports and out of Europe where they had mares so the mares of these Foals that they were treating developed severe colitis and some of them died. We haven't seen that very often, but it's also something to take into consideration. Monitor the mare, be sure that the mare is not getting soft manure or getting sick. But like I say earlier, there's a need for changing the approach to treatment. And I think now most people understand that, and we're all working on a balance. And there is not going to be a recipe that can be applied to all farms. I think each farm needs to slowly start stretching. It's going to depend also on the owner of the farm, how long they're willing to wait. But it was not an easy sell, I think, at first, because everybody's like, and I always, if you see abscesses as a veterinarian, it's hard not to do anything. And I can tell you just a side story, when I was doing my PhD, I did my PhD under Dr. Horhoff supervision, and he's an immunologist, but he's not a veterinarian. And by then I was a internal medicine diplomate. I have seen a lot of foals, a lot of abscesses when we were infecting these foals, and we will do ultrasound. And I will see the foal grow. We ultrasound them twice a week, and I could see the abscess growing. And we were waiting, right, on these foals. And I was like, oh, there's no way this foal is going to clear this abscess. And our way to go about this was like, we used to bet Malbecs, because I'm from Argentina, right? And Dr. Horhoff likes, like any other person, good wine. So we used to bet Argentinian Malbecs. And I can tell you, I paid so many wines to Dr. Horhoff. I think he had a stash, by the time I finished, because some of those foals had massive abscesses. And then one day the abscess stopped growing, and then they will fill in and they will heal on their own. So patience is nerve-wracking. And I understand the pressure of, you have a super expensive foal and the owner sees the abscess and you want to treat it. But I can tell you, my experiences, they will heal. And of course, nobody's saying don't monitor horses. I think close monitoring and watching those foals closely will do us a lot of good. Just wrapping up a little bit, what about prevention? We talked about there is no vaccine. There are a few groups working on vaccines right now. The only problem with vaccines is, before we thought, again, back to our understanding of this disease, we thought foals got infected like when they were 3 months. So there was time for vaccination. Now we know they get infected as they're born. So vaccinating newborn foals, I've done that for research, is very unrewarding. They don't respond very well to anything. And also you need 2 doses of vaccine. So by the time we get the 2 doses, so a dose at birth, those by the time they're 3 weeks old, they're no longer susceptible. So vaccinating foals is unlikely to work. I'm not saying it won't. It's unlikely, I think, to prevent infection, and might aid or help a faster recovery, a tougher immune response, faster clearance. That might be it. But as prevention of infection, I think it's going to be hard. And that's why we're looking at vaccinating mares. And this is not a new concept or idea. We just try vaccinating mares for the longest time, and there's a lot of conflicting evidence on that. I think as vaccines get better and our understanding of maybe protection and immunity of these foals is better, we will end up getting some sort of vaccine that we can give mares, or plasmas, which is what we're using now. And the concept of plasma is, we vaccinate mares, we bleed, or donors, blood donors, vaccinate them with Rhodococcus. They mount an immune response. Then we take that plasma that has antibodies and other proteins that we don't know what they are or how they work. And then we infuse this to newborn foals. And for the longest time, there was a lot of conflicting evidence about, does it work or it does or it doesn't for plasma. And I think it had to do a lot with the dose that we're using. When we were giving the plasma, it's not the same to give a liter to a 50-kilo foal or a 100-pound foal at birth than giving a liter to a foal that is a week older, where they're much larger and more dilution. We have looked at plasmas, at the products themselves, and there's a huge variation in this plasma products, even if you buy the same lot. which is crazy to me because they're not cheap. These plasma products are expensive, but they're very variable. So maybe that also adds to this variable results. I think now that we know when they get infected and we're focusing on giving these plasmas first, those first few days of life, we do see, and I think most people will agree, that good quality plasmas will decrease the disease severity. And if we give, there's recent information just out of this 2021, there are multiple studies that look, they're retrospective, so we need to do more work. But at least we have some evidence that giving 2 liters of plasma is better than 1 liter of plasma. Now, when we give plasma, we don't only give antibodies. We give all kinds of things, including some unwanted viruses to these Foals. So we need to look at what are we giving? Are there any other proteins other than antibodies? Any of those could be more beneficial because maybe we can get a more purified version of plasmas that will be more effective. And I think that is all to come as we understand better this disease. We do know for sure when you give plasma, they get less severe disease, so they're able to clear better that disease, and that results on a less number of Foals that you need to treat. That has the caveat, though, that you have to wait because plasma doesn't prevent infection. So you will see, if you're doing ultrasound, you will see the abscesses. So as abscesses is the end point for your treatment, plasma doesn't do any good because you will have the lesions. But we've shown on experimental infections that they get less severe, smaller size abscesses. The white cell count doesn't go as high, or for that long. So the inflammation is shorter because they heal faster. And also, we looked at the manure of these Foals, and they shed a lot less pathogenic Rhodococcus. So, of course, we didn't look into what will this do over the years, but you would think that if the Foals are the main shedders and we can decrease that with plasma, then there will be less shedding and less. There's always going to be Rhodococcus, but at least we will decrease a little bit that pathogenic load, or that's the hope. We have not done the research to prove that, but we looked at the manure of these Foals, and for sure the ones with plasma had less Rhodococcus. So I think it's a lot of work is going to come out now that we have our headset on. We need to do less treatment and find better prophylaxis and better diagnostics to identify these Foals that really need treatment because Rhodococcus is very common and it's not going to go anywhere. So I think this need of new strategies, everybody's working together now, which is also very nice. We have the ability to share information a lot easier than what it was years ago, where you had to wait until someone published something or you had to get to a meeting. And now with communication, it's a lot easier. So I think we'll move faster at a very slow pace compared to other species because we have a long wait for Foals for any in vivo experimental project that we wanted to do. So I really hope this was helpful. It's a lot of information, but I was trying to give a brief kind of like what is new, what do we know out there? And it has been a great experience. So I hope everybody will enjoy it.
Well, Dr. Sanz, thank you so much. Having lived and worked in the thoroughbred industry in Kentucky for many, many years, I think that a lot of people are going to be very interested in trying to hear what you have to say today. And we certainly appreciate you taking the time. And I am going to include an outline that Dr. Sanz gave to me that kind of covers some of the things she discussed today that will be in the article on equimanagement.com that goes along with this. So again, thank you very much, Dr. Sanz, for joining me for this episode of Disease Du Jour, and thank all of our listeners, and a special thanks to our 2022 sponsor, Merck Animal Health. We invite you to listen and rate episodes of Disease Du Jour on iTunes, SoundCloud, Stitcher, or wherever you like to listen to your podcast. And if you have any questions or suggestions, You can send an email to me at kbrown, that's the letter K Brown, at equinenetwork.com. Disease Du Jour is a production of the Equine Podcast Network, an entity of the Equine Network, LLC.